It really is great to be here. Toronto is my home, and the last 3 years I have not spent nearly as much time here as I would have liked to, but been delighted to serve as the president of the International Council of Nurses and be all over the world and see the global health issue from different perspectives. I've been involved in international work for decades, but this appointment as the president has given me more of the nursing lens in the context of global health. I always say that the first issue for us as nurses and for ICN is to look at the health of the 7 billion people who live on this earth. It's really advancing nursing and health worldwide is what we are talking about. So there are two Twitter tags there, one of the ICN and the other is mine, and I am delighted that for once I don't have to tweet because you guys are tweeting continuously, so thank you for that. Okay, let me tell you just very briefly about the International Council of Nurses. The Canadian member of the International Council of Nurses is the Canadian Nursing Association, which is an amazing member. It has been a major contributor to a lot of different issues, and the ICN always can call about CNA, and CNA will do everything they can to support the agenda. CNA is also the vehicle that ICN will get in touch with the federal government and communicate some of the policy discussions and solicit some of the support. I am only the second Canadian to be a president of ICN over the last over 100 years, but the CEO of ICN, 2 times removed, Judith Alton, a name that some of you would recognize, was a Canadian, and she was the CEO of ICN for over 10 years, and under her leadership, a lot of great things happened. The other thing I would say about Canadians is that as I turn around, regardless of where I go to very global meetings, you run into a lot of Canadians. So we should be very proud of the contribution we make globally. And I think the evidence of what you do is demonstrate the caring and the compassion and the concern that Canadians have for the citizens of the world, whether it's in the area of health or other agendas. I'm going to talk for a minute about being engaged globally and the word impact, and I will tell you why I am doing that. It's not for self-promotion. When I became a president, I was told that I have to have a marching word ready that I have to be able to talk about if I get elected. And I kind of thought, how can you take one word and capture what you hope to do? And in many ways, I thought that was such a silly thing to do. It's childish. Well, when I tried to come up with a word, I struggled. And we threw around probably 30, 40 words from inclusion, engagement, partnership, you name it. And I landed on the word impact. And the reason I landed on the word impact is that the reason that I wanted to become a president and I campaigned, and I had 3 people campaign at the same time, is that it's been very clear to me that the role and the contribution that nursing makes to global health far too often not understood, it's not appreciated, it's not included, it's not present in many forums. And I can go through the forums of where and why and how. And it was very clear to me that if we wanted to have a better world and we want to have a healthy world, we do need to have nursing part of that global health agenda. And impact was the word that kind of resonated, and it continuing to resonate. So in hindsight, that was a perfect word to choose. And I would say further to that comment is that I'm less concerned about the impact of nursing within nursing. While we can talk about it, it's important, that's not really where I spend my sphere of time and energy, although I meet with hundreds and thousands of nurses across the world. Where I encourage many of us to spend a lot of time also is what I call outside of the nursing bubble. And whether it's the organization bubble like the SickKids, or the provincial bubble and the Lynn bubble and the global bubble. And if you look at some of these pictures, to the top on the left, that's in some of the UN forums, and it's very hard to find nurses there. And when I go to the World Health Assembly, which is the Ministers of Health, every May, and you want to try to see how many nurses are Ministers of Health, you can put one hand behind your back, and maybe you need this hand. Sometimes yes, sometimes not. So when we know how much we know and how much we can contribute, it becomes an issue. And then you have the opportunities, like here, the bottom left is with President Ma, who is the past president of Taiwan. He just stepped down a couple of months ago. And I had the most interesting encounters with him. In Taiwan, for example, it's mostly run as a country on specialists and not primary health care and not family physicians. But when you look at their clinical outcomes, in spite of the fact that they have incredible access to specialists, their health outcomes are not as good as it should be, and a lot of issues around chronic illness. So the conversations with him was outstanding. He was also the mayor of Taipei during SARS. And I was, by the time of SARS, I was at the federal government as the chief nurse of the country, so we had a lot of commonalities there also. But the opportunity to build relationship and communicate some of those messages that the politicians might take it or leave it, but at least they hear some of the perspectives of how their countries and how their contribution can be made is important. And I have to say that Taiwan has been absolutely phenomenal in supporting other developing and developed emerging countries, low and middle income countries, on many initiatives. On the right side is one of the forums. We have a large Spanish contingency, and language is always an issue, and how we will work together with groups in different forums and helping to tool up and scale up with information and knowledge and experience others that can move the agenda forward. This is the commission that Pam mentioned. This is a commission that the Secretary General of the UN announced in March this year, and he established a commission of 17 commissioners that has to table a report that looks at healthcare workers and economic growth, which again, it's a lot of conversation that we can have, and through my stay here for the last couple of hours, I had some interesting conversation with different individuals. But basically, it's trying to shift the narrative from saying that investing in healthcare workers is an expense to the narrative that it's an investment. And it's an investment, and I will give you a small example. As we went around and visited some of your units, and the new unit that you established July 1st, which is the unit where you provide focused care to some of your complex medical children and their families. When you take care of them and they can go home sooner, their family members can go back to work also. So it's, when you think of economic investment, it's not just what you reduce the cost within the hospital, but how the individuals that are the caregivers and so on able to function in many different ways and so on. The interesting point here, and I can talk about, this is for one of those policy classes or a policy chapter in the future, the interesting piece that among the 17 commissioners, I'm the only healthcare person. Everybody else is a politician or other form of advocate. As you can see, Zuma and Hollande are there, and Margaret Chan, who is the Director General of WHO, and it's under the umbrella of Zuma and Hollande. There are 3 organizations, ILO, WHO, and OECD, that are driving the work around it. And it is our responsibility as commissioner to receive the evidence-based information, and we are just in the process of looking at that and saying, okay, what should be the recommendations for heads of states in September, in recommending to them how to move the health workers' agenda forward. And the projections that we have from countries like from organizations like OECD and the World Bank is that between now to 2030, there will be an additional need for 40 million health care positions. And they are not all nurses and doctors. There might be people who deal with logistics or pharmaceuticals or others. And out of those 40 million, 22 million will be in the developed countries, in the OECD countries, including Canada. So how are we going to achieve that, and how are we going to move the same time the global health agenda is really the question. And by being engaged in some of these forums, you can bring the global health and the nursing perspective to the picture. So how many of you, and just show me a show of hands, familiar with the Sustainable Development Goals? Wow, that's amazing. There is some recent research in Canada that shows that most healthcare professionals know very little or nothing about the Sustainable Development Goals. So as you would know, the Sustainable Development Goals is the next generation of the Millennium Development Goals that had a lot of focus on areas that you are very engaged with and interested in. It's maternal child mortality. And it took us a certain level forward, but not far enough. And this, which was approved by heads of states in the UN last September during their General Assembly, makes an attempt to do something different. And the Sustainable Development Goals targeted until 2030. So we really have 14 years to move forward. What's important for us to understand, because first of all, I would tell you that the Sustainable Development Goals are relevant to all of us, whether you are low, middle, or well-to-do country. There are issues here that are relevant to all of us. And a lot of the funding agendas and a lot of moving forward will be very much nested in this and in universal health coverage and people-centered care, which are the three kind of the buzzwords that are being thrown around in various conversations. The issue here, which I'm going to go through in my presentation, is that most of the health type, like those of you in the room and online, focus on the third goal, which is good health. And while I will go through some of that, I will make the case for you that each and every one of these goals are something that should be of concern to us. Because I make the case that there is no health if there is hunger. There is no health if there is poverty. There is no health if there is women abuse and lack of education and so on. So I think it's important for us as healthcare professionals to understand the complexity and the global essence of it. And while it's interesting in a global sense, I would also suggest that each and every one of our daily work, when we do whatever we do, whether it's research or patient care or work with families, keeping some of this in mind, it becomes essential as number one. And number two, ask the question of how we, as organization or individual, link to other organizations in our own community or otherwise to advance some of these issues. So now I'm going to delve into the Sustainable Development Goals to some extent, because I think while many of you are aware of it, I just want to push it one layer lower and bring your attention to some of these issues. One of the targets, and each one of the goals, the 17 goals have like 179 targets. I don't know how one manages that, but again, those are some of the challenges and some of the questions of saying which targets are more relevant to the scope that we are looking at and how can we contribute to it. And there is a whole larger group of discussions that are going on both at the UN and globally. I would make one other comment around this driven by the UN, and that if I would have stood in front of you 20, 25 years ago, my comment would have been that most of the things that are relevant to global health comes out from the World Health Organization. Well, that's not the case anymore. And in many ways, HIV/AIDS changed it. That was the first time that the UN had a major summit of the heads of state to come up with strategy and so on. And the next one was about chronic diseases and so on. So there is the understanding that health is bigger than the ministers of health portfolio. And unless it's being dealt with in a more global sense, there is a risk that everything else will suffer. So one of the targets under the health, under goal 3, is that by 2030, reduce the global maternal mortality ratio to less than 70 per 100 live births. And I would suggest that each one of you, depends, regardless of which profession you come from, ask the question of what does it mean and how can we move that forward and what are some of the issues. Now, when it comes to nursing, because a lot of this lost life far too often happens in rural setting outside of city centers, and nursing plays a very significant role together with midwives, with traditional birth attendant, with community health workers and others. But as you can see, there is, and regardless of the specific numbers, you can see the colors. Basically, there is a long way to go. And as I said, we made some progress, but we have a long way to go. And the question becomes, what are some of the issues that we need to look at it to reduce maternal mortality? And some of the evidence and some of the key interventions to reduce maternal mortality rate are in front of you. Managing maternal anemia with iron, preventing and managing post-partum haemorrhage, immediate thermal care for newborns, extra support for feeding small and preterm babies, antibiotics for the treatment of pneumonia in children. So when you look at it and you think of it, the role of nursing can play, it's pretty clear. I don't think I need to belabor the point of the knowledge that nursing and others have. And again, there is a trend across the world for nurses to have prescriptive authorities. And in many of the rural health settings, nurses and unfortunately less qualified individuals dispensing medicines. So a lot of these issues can be managed in many different ways. There is also growing innovations around managing postpartum hemorrhage and thermal care. Some of you will be familiar with JPIGO, which is an NGO, and they've been working on a lot of various other innovations to have a simple gadget to do infant CPR in the community, and been teaching nurses and community individuals and so on. But there is a lot of work, and depends on the country and depends on the community. But as you look at even just these interventions, you can see that this is high touch, low technology interventions that are required to move the agenda forward and reduce the maternal mortality rate. When you look at the preventable death of newborn and children under the 5 years of age, in last year, in 2015, over 6 million children died under the age of 5. And the research would suggest that over 50% of it could have been prevented by very many other ways. Another target is the end of epidemics in AIDS, tuberculosis, malaria, and other communicable diseases. Again, another piece of work shows that in Canada itself, 1 in 5 individuals that have HIV is not aware of it. Okay, so if you look at the role of nursing, you look at the role of public health, you look at the role of others, trying to identify people at risk, trying to make sure that they get tested and do the right intervention. The same goes for TB. We used to think that it's no longer a problem in the developed countries, but it is so. The whole area of non-communicable diseases, which you know as chronic diseases in this country, and mental health. Again, nurses have a significant role to play in those areas. A lot of it is through education, through discussion, through building relationships, providing continuity of care, and I was absolutely impressed by finding out how many nurse practitioners you have in this institution alone. Because while the nurses' involvement is phenomenal, unfortunately, because of the shift work and so on, it's not always possible to keep the continuity that the nurse would like to have, and having the additional support of a nurse practitioner might add to those areas. But that relationship and support and trust and education becomes extremely important. Use technology to advance care provision, support adherence to long-term therapies, promote collaborative practice. Technology is a huge issue, and often you hear, oh, in Africa there are more cell phones than whatever. The issue is that while technology is essential and there are incredible number of innovations, oftentimes the technology doesn't reach the unreachable areas. And even in our own country, if you go up to some of the Aboriginal communities, they don't have wideband access, and it's very difficult to try to do telemedicine or try to communicate through for them to access internet and so on. So again, I think the message I have here is that while we have a lot of interventions, it has to be done in an infrastructure that's supported by others in order to make sure that we can actually communicate and make the impact. Substance abuse, and again, I am running out of time, so I am kind of speeding a bit, but I am more than pleased to leave my slides with you. You're welcome to use it after. Again, when it comes to substance abuse, including narcotics, drugs abuse, harmful use of alcohol, you have such a unique opportunity connecting with children and families, and nurses generally have the links, and if it's in the community level, they are part of the community, and they do know where are the issues and where are the problems and how you work in partnership with others, whether it's the religious leaders or others in moving some of this agenda forward. I'm just going to say a word about universal health coverage, which is the other big buzzword currently globally, and the idea is to make sure that every person has access to basic care without financial burden. So it's different than what we call universal health coverage in Canada. There are tens of millions of people who every day have to make a choice of getting health care to their children or putting food on the table or do nothing. So the World Bank talks about trying to get universal health coverage for people who earn less than $1.75 a day, which is the kind of the absolute poverty level. And even if you look around us, I remember when I worked at Sinai and would go to Sinai and see people on the middle of the street and so on and so forth. There are lots of people that do not have the resources. I remember visiting Yukon when I was the chief nurse, and the woman told me, and many of you will understand the implication of it, that she only takes half of the pills that she is prescribed because she needs the money also for food. Well, that half pill might be doing more harm than good. So I think all of that is an issue. Global strategy for human resources for health and the workforce. I mentioned to you the Commission, but also the WHO just passed this strategic document about Workforce 2030. There is strong recognition that we need the right people in the right place. We are very short of nurses and doctors and other healthcare professionals in rural and remote areas. Most of the professionals live in urban settings, and also many of them migrate from countries, so the working conditions become essential, and you can find a document on the WHO website. I'm going to say literally a word about every one of how many minutes I have left? Okay. Literally a word about the other goals. So until now, my comments were around goal number 3. And again, the targets are well articulated in the UN website. You can go back to it, and if you get very ambitious in saying we should adopt X, Y, and Z, then say these are the ones we're going to work on, because it's unrealistic to assume that you can put your arm around all of them. Poverty, I just mentioned poverty, and again, my message in going through all of this is to reinforce the message that when we look at health, and when you look, let's say, at acute care or even public health, it's not enough just to look at the clinical situation in front of you. You have to keep in mind some of these other issues and continuously look for it and see how you, as a practitioner, whether you are a nutritionist, a nurse, a physician, a pharmacy, physio, whatever role you play, what's your role in making sure that you are moving the agenda forward? And again, I think when it comes to poverty, you might see 3 kids with the same issues, and you know that one will go home and will not be able to get the care needed. Another can go home and you know they will buy private this, private that, whatever. So I think the poverty issue is essential. And in this country, more than in many other countries, there are opportunities to make sure that people know how to help themselves and how to get some global support. But you also encounter a lot of people who come from other countries who don't necessarily know the Canadian system, so you can be helpful in saying to them, have you got in touch with so-and-so, and here is somebody who can help you identifying those things. Strengthening women and children capacity to exercise more control over their lives. The whole agenda of women violence, women employment, youth unemployment. 1 in 4 people in this world is youth, and there are over 76 million youth who is unemployed. And that's significant. If we say that we need 40 million new positions in the future, how are we going to build a system that will embrace youth and women to make sure that they benefit from it? Second is to end hunger and achieve food security and improve nutrition and promote sustainable agriculture. Again, there is a lot of research going on, how you produce food that it's high in nutrients and provide what needs to be done. Again, we all hear the stories of children going hungry to school, and we know the relationship between brain activities and food and nutrients and empty calories. Again, in our own country, you can go up to reserves or to the territories, and it's cheaper to buy a soda than milk, and so on. So there are a lot of policies and other issues that we need to keep in mind, but we have to end hunger if we want to also make sure that there is global health. Inclusive and equitable quality education and promote lifelong learning opportunities for all. It is absolutely tragic to see how many girls do not get education in many, many countries, whether it's from religious reasons or because boys come first. But we know that when we educate a girl, first of all, the HIV rates go down, their income goes up, the number of children they're gonna have goes down, and there are a lot of international examples, and I'm just not going to go through it. But any effort we can make in our global work to make sure that girls get educated, it should be done. So one of the things that we do at ICN, which I'm very, very proud of, there are many nurses who gave their life through the line of duty and died in Africa. And during the HIV outbreak, we have established a program called Girl Child Education Program. And we admit orphan girls of nurses, whether men or women, who died. And we help them to get through elementary and high school education. And our results of these girls is phenomenal. There is no other program that achieves what we have been able to achieve with literally 0.001% teenage pregnancy. The dropout rate is negligent, and many of them continuing to university and higher education. And we know that and they don't have to become nurses. That's not our interest is to educate girls. But what's so interesting that one of my colleagues, and I have to say this because you're familiar with some of that research, and the penny dropped for me, and I said, why our program is so much more effective than other programs in Africa and so on. What we have is that each one of our girls have a nurse mentor, and it's usually somebody who knew their mother or father. And if you remember, there are studies by Old and others that show that by having one home visit for a newborn infant and the mother will reduce the number of violent children and adults later in life and so on. So we really need to do some research to demonstrate whether really the impact we see with such an incredible accomplishments has to do with the fact that they have a nurse mentor or a partner or whatever we want to call it. The letters I get from fathers and girls about the program is unbelievable. Gender equality. Do you know that even in this country, and I think, and I'm coming to an end, that even in Canada, among the OECD countries, we have the 5th highest gap in wage gap between men and women in this country. Okay, so we talk about gender equality in many different ways, but we still have a long way to go. Ensure availability and sustainable management of water and sanitation for all. Again, I keep bringing it home because I want you to walk away from here today saying the Sustainable Development Goals relevant to us. Do one thing if you have time. Check on Health Canada's website how many communities have a drinking water alert every day, and you will be shocked. Because you would think in Canada, you can drink the water anywhere. You will be surprised how many communities have a boiling water alert. And of course, it's needless to say that when you go to communities, and again, there are studies that show how much more time women spend on fetching water than men, and the diseases that are associated with it are quite incredible. And the worst story I heard recently is that I don't mean ICN, but we went and taught the community and birth attendants that they need to boil water when they doing the procedures to deliver a baby, and we did not tell them to cool down the water before they used it. So the bottom line is that you can never be too careful, and you never can be too cautious. And you can never assume that what we take for granted others do. My daughter, one of my children is a pediatric dentist in New York, and she studied in Columbia. And she always used to say to me that when teenage moms used to bring their children to their clinic, she always had to remember that these are not her friends from Toronto. She had to educate them in a very different way than if she would be talking to one of you that come from a different context. So again, I think we just need to remember some of those things. I'm not going to talk about it. It's basically essential elements on delivering SDGs. And again, it's the basic issues of taking into account people, dignity. It's all about context. And the context, again, will be very different right here. So when you walk into a room of a patient, and children and family, if they come from recent immigrants to the country, or they don't speak the language or whatever, you will see that the context would be very different. The bottom line is that we need to have a seat at the table, and we need to have the seat at the table to bring the knowledge, the experience, the wisdom, and the care that we have. And as Pam went briefly through my background experiences, unless you are at the table, yes, you can keep lobbying and you can be advocating and so on, but being at the table gives you the opportunity in a collegial manner to put the issues on the table. And my call for action to you is based on your passion and your interest. See where you can get a place at the table. And it might be a community community committee that looks after playgrounds, or does something else in the community or in your church or with seniors, whatever it is. But try to get involved and grow with various initiatives. What you do every day is terrific, and thank you for all the care that you provide or manage day in, day out. But there is life outside of our immediate professional employment, and finding those opportunities and getting involved would help you to get a seat at the table, and it makes a huge difference. Please come and join us in our Congress in Barcelona next year. Thank you.
Thank you very much, Judith. Any thoughts that Judith has stimulated or conversations you would like to extend?
You mentioned the WHO Global Strategy on Human Resources for Health Workforce 2030. Could you say a little bit about what that document says specifically about the role of training nurses in the developing world, and how either what one has to do to achieve by 2030 the goal of training enough nurses to meet the needs? And maybe if they talk about nursing for children, we'd even be more interested.
It doesn't go into that specific detail. It goes into the principles and basically advocate that each country should have a plan of projecting how many nurses they need, not how many nurses, how many healthcare workers they need, talk about the need to work in a collaborative team approach, and it talks about the need to make sure that people are trained and have the working condition they need to the level that they need. So it's a thin document, it's principles. The issue when you try to pass a strategy or a convention in a global level, the less you say, the better the chances are that countries will support it. So it has some key principles and it has some data, but then it makes reference, and really I think you might be better served by looking at a recent document that came out of OECD that looks at the number of nurses, number of doctors in different settings, and have that conversation. I think part of what will come out of the Commission work, because the Commission has 3 parts. One is expert commission, expert data that it's chaired by Richard Horton, who is the editor-in-chief of Lancet, and there will be multiple pieces of documents there, including education. Then there is the commission that has to approve the political agenda, and in between is what we call our Sherpas that bring the two together, that prepares the document to move forward. But in the evidence pieces, there will be papers on education, and I think that will give you some of that perspective. What I've been pushing for is transformational education, which means that we should have a career trajectory of education. And because I'm so passionate about women and youth, I'm willing to admit to that trajectory someone who has maybe 4 years of elementary school. Let them learn something simple, stacking supplies on shelves, and then help them to learn something else, and let them learn something else, and then let them go and become an assistant physio, assistant pharmacy, assistant nursing. Then they want to become a nurse, a dietitian, a physician. It's a trajectory a lot of people want to learn, a lot of smart people out there, but circumstances did not allow them to achieve their life goals. So that's one thing I know that I am pushing for. I don't yet know what will end up in the report. And again, the report and the recommendations are going to be very broad, but what it will do, it will allow us to take it and try to frame it to our countries. So if it's Canada or the US or Zambia or Ghana, you can take them and turn them into what's relevant to that context. But there is a lot of discussion and work on education. The other thing that is very big, and there is a growing recognition of it, is that if we want global health, we cannot continue to prepare people for acute care only. We need to transform to primary health care and understand that context. I was saying to a group over lunchtime that, interestingly enough, one of the things that mentioned in most of the documents is the Northern Ontario Medical School, as an example of how, by thinking differently and taking the educational side and admitting students that come from those communities, the likelihood that they will stay in those communities and serve is higher. So I think when you look at those documents, you will find some of those points, but I think we are trying to push the boundary. And I guess in 3 to 4 weeks, I will know better how far we will be able to push the boundaries as it relates to the UN document. Okay?
Thanks. Zulfi, I think, did you have a question?
So thank you very much. I have two related questions. One relates to the whole issue of how we are approaching the global workforce through numbers. So there is this whole issue of talking about averages in terms of the numbers, and some of us have been pushing for distribution as opposed to numbers. So I'd like to hear your views about this. The second is probably a trickier or a more difficult question, and I've struggled with it myself. And that relates to so in the world of maternal health and maternal newborn child health, this whole confusion between the role of nurses and the role of midwives, whereas some of us who are on the ground don't really distinguish between the skills of nurses and the skills that we have independent of midwives, and it's causing a huge amount of confusion in countries because in human resource development you don't have the luxury of creating separate streams when there are already with regular nurses, registered nurses, capacities to provide midwifery support.
Right.
So I'd love to hear your views about this as well.
So I'm going to start with the second, because we already talked a bit about it earlier, but also it's a major concern to me. I would say to all of organized groups, including ICN, ICM, other organized global groups, we have to keep our eye on global health first and ask the question of how you achieve global health. And the tension between nursing and midwifery and so on is real, just like there is other tensions between different professional groups. And it's an unnecessary tension. And the tension emerging primarily because there are two ways to enter midwifery. There is a direct entry or nurse midwives. And until we stand on a podium and say loud and clear that at this point, both of those entries are real, and we have to figure out if there is a unique function to each one of them, or they are able to function in the same way, we're not going to have the outcomes we're looking for. So for example, in one of the African countries, they were convinced that they should have a direct entry to midwifery. They produced their first 2 cohorts, sent them out to rural settings just to discover that it was a miserable failure because the individuals did not have the skills to deal with the clinical issues that come in addition to the midwifery challenges. So now they brought them back to work in the city, in the hospital, and the nurse midwives are continuing to be in the community to deliver the care. So unfortunately, politics seem to play into a lot of this, and it shouldn't. I think we need to find out, based on the best evidence, what works, what doesn't, and how we build the teams. I actually thought you were also going to ask about community health workers, which is a whole other phenomena, and traditional birth attendants, which is a whole other phenomena. But if we can't think of the whole care and health in the integrated fashion with whoever is there, so if there's a midwife, and if there is a nurse, and if that nurse is also a midwife, and there are community health workers, and if there happens to be a teacher or a priest, how you all work together, we are wasting resources we don't have. So it's a conversation that doesn't happen as openly as it should, but it's a reality that there is that tension there, and it depends which head of state you talk to and which Minister of Health, or better yet, which Minister of Finance. Your first question was about? Absolutely. The distribution issue is huge, and I think that we're starting to see some of that attention, and there is more and more conversation around context. So we're doing some work with a major international organization and looking at what the team should constitute in Zambia. It doesn't mean that that constitution will be relevant to Lesotho or to South Africa, that are neighboring countries. It very much depends on the context, and you need to know your distribution. And it requires, there's a lot of discussion around large data, and I think we are nowhere near exploring large data elements. I think large data, while it sounds that it's more aggregation, it could help with the distribution and showing us what is available, what's the patterns, what might work, what might not work. But we are nowhere near that information. Okay. Marlene.
Thanks. Marilyn?
Thanks very much, Judith. It's great to have you here. As I think about the latest UNICEF report about the health of Canadian children, it seems that we're losing ground compared to many countries. And it's really shocking how poorly we score on many health indicators. Many of them obviously related to poverty and other variables that you've talked about. But the group of children and youth that worries me the most are the Aboriginal children and youth. And we seem really perplexed in this country about how to support those communities. And even as organizations, and I am the chair of the board of the Canadian Association of Pediatric Health Centers, and we grapple with this question of how do we use our organization to impact positive change in those communities. I think the Canadian Pediatric Society does the same thing from time to time, and I think we're all perplexed. Do you have advice for us? Are there fatal flaws in how we've been approaching it, or is it simply a question of more money, which I will say the government seems to talk about?
Yeah, I don't think it's an issue of more money. I think it's more an issue of letting them guide what needs to be done rather than Toronto or Ottawa or Montreal telling them what needs to be done. And understand how community development works. And part of the other reason, in my opinion, and again, I am dying for someone to do some more research on it, that in spite of the amount of money we spend in healthcare, and we are spending enough money on healthcare, I know we always want more, we don't do a good enough job of spending sufficient money on social services. And until we deal with social services the way it needs to be dealt with, the health outcomes will continue to be inadequate. One of the countries that I look at, and that's the comparative research I would like to see. You look at a country like Israel, they spend half of their GDP that we spend on healthcare. Generally speaking, some of their outcomes are some of the best. But if you look at what they have as what they call mother-baby centers, that it's fully staffed by nurses, every mother and baby is tracked, so the early childhood, whether it's violence or whether it's immunization, gets tracked in a way that that nurse, it's usually a public health nurse, knows inside out and will go to the home and do things, and then other social programs. And I think that's the missing link. I don't think we have some of that infrastructure. My family moved to Canada in '75, and at that time, I moved from Israel. I had two children. One was 3 years old and one was 2 years old. And I think during their collective 5 years of life, maybe I have seen a pediatrician 3 times. Then I had my third baby in Montreal at the Jewish General. And over her 5-year life, I don't know, 24 times for every vaccination, every eye check, every normal assessment. we need to look at the social structure and the social programs. And in many of those communities, we go in and we try to tell them what needs to be done. And I will never forget when I became the chief nurse in Ottawa, Alan Rock was the minister, and I was asked to go and meet him. And I was targeted to do policy work. And his comment, and that's the only line I remember from my hour with him, he said, if you think that you will be able to stay away from the Aboriginal agenda, you are wrong. And it stayed with me forever. And the more I looked at it, it's white people trying to manage. And I think it's a lesson I learned through my international work. That doesn't work. You get there and you become native, you know? And I'm not saying it in a derogatory way in any shape or form, but you need to walk. We talk about empathy. You need to walk in their steps, not them walking in our steps. It just doesn't seem to work. It would be easy if you could send a formula, or you can send an app or whatever. It doesn't work that way. So I think that's the issue, in my opinion. Okay. Oh. Ashley.
Ashley, one more, I think, and then we'll wrap up because we're at the end.
Perfect. So you recommended us to get a seat at the table if we're passionate and we want to have a voice. But navigating those waters to find a spot at the table can be tricky. What are your recommendations for us to pursue that?
So on the joking end, I am finishing my term next May, and this is a volunteer job. So I quit paying jobs, and I've been doing I will do it for 4 years as a volunteer. My next job is to try to make a lot of money in order to have a boot camp for nurses. And what I want is to sign up people like you and say, okay, your next 5 to 10 years is signed over. And we will work with emerging leaders or mid-career in learning different things to get to the table. Because again, you haven't finished your nursing school, whether you have undergraduate or graduate, with too many courses that gave you the tools of how to sit at the table and what to do and how to prepare for the meeting and so on and so forth. So again, we ask you, do policy, but we don't teach you. So that's kind of in the large answer, but in a concrete answer, attach yourself to one of these great leaders that are in this room, and they don't have to be a nurse, and ask to be mentored, and do the plan of the next 6 months, which table or which things I should go to. How many of you ever went to a meeting at City Hall to listen to the health committee discussion? 2 hands, and you work in public health. 2 hands. Let me ask you the next question. How many of you have actually had a policy course in your formal education programs? Fair number of you. So I expect each one of you to have in your resume something that you have done with it. Otherwise, it was a waste of my time and your time. No, seriously. But I think I know you walk out of here and you say, I'm going to do it. And by Monday next week, it's kind of, okay, that was interesting. I have no time. The no time is the kind of the excuse of everyone. But if you are really serious, then sit down with one of your colleagues and make a pack of saying, okay, let's figure this out. And let's check in once in 2 weeks and see how far I went with it. Who did I talk to? What did I try to do? And so on. There are incredible number of opportunities, and many of the smaller, not-for-profit, community-based organizations would be delighted to have a nurse on board. And I think the question is what organizations SickKids are connected with in relation to serve your patient population. And are there opportunities there to get a seat and get involved with the program? And it's one thing to deliver program, but I want you to have a seat at the table where the discussions are about what program will be offered or what policy. we were having some discussions. You were there, I think, Ashley, when we talked about, I was asking what support your patients, the complex patients, get when they go home. And it's clear that the policies of the government are not sufficient to support those families. So the families pay a price, and if they can, that's great, but it's a huge burden. How you advocate for those things? So I'm not expecting you as Ashley to do it, but does the organization does it? Do they go to City Hall, or they go to the LINS, or they go to the government and say to Bob Bell, come and visit, and let's have a conversation? And I assume you guys do a lot of those things. But please include the younger generation. If we don't train you guys, when we are done, we will just say, oh my God, who's gonna do it? And you guys gonna do it. You know, as Pam said, I've been around for a long time, which means I'm old.
Well, thank you very much, Judith. Old and wise, and very young at heart and young in spirit. So thank you.